All right, good morning, everyone. Good morning, good morning. Go ahead and find your way to your seats. I want to just extend a wish of gratitude and thanks to Patrick Motion and everybody on that last panel. Even if he was heckling me from the stage, that's totally fine. I think it was really helpful, and we learned a lot about ways to be engaged and find joy in the little things. I'm really excited about this next session, which is going to be led by Dr. Leanne Ward. Dr. Ward is an endocrinologist who specializes in bone health and Duchenne. She's really a world-class leader as we think about how to care for dystrophinopathy and bone-related health. She has led us as we have brought together leaders from all over the world in a series of meetings last year, which she shared a little bit about earlier this week, both in Rome and subsequently in Ottawa. And so I'm really excited to have her come to the stage today and talk a little bit about some of the work groups and the work that these different folks are doing to really push the needle in terms of endocrinology care in Duchenne. And then she's going to lead us in some additional conversations with a few of our industry partners. So Dr. Ward, I'm just so happy to have you with us. I'm going to turn things over.
Thank you. Thank you so much, Rachel, for that introduction. It is just so wonderful to be here. I'm so impressed with the vibe of this conference and the information sharing and the fellowship, and it's really, truly an honor to be here to talk about how we're moving the dial on endocrine and bone issues in Duchenne. These are my funding sources, and these are my disclosures with funds to my institution. And so what I'd like to do is talk about the current state of the art, but how we're trying to really advance care in the areas of endocrine and bone issues, including prevention of first ever fractures, prevention of excess weight gain, adrenal insufficiency awareness, and trying to tease out the relative benefits and risks of the different therapeutic approaches that you all have to choose from as you go forward in the care of your children and adults with Duchenne. A couple of days ago, we talked about the fact that the Duchenne itself, even in the absence of steroids, causes bone fragility known as osteoporosis. And individuals with Duchenne are a little bit shorter than typically growing peers, and they also have a tendency to gain excess weight. And then when you bring steroids on board, then the osteoporosis risk is amplified. The short stature can be exaggerated in some cases. The excess weight can escalate, and then we can newly see delayed puberty and adrenal insufficiency. The best therapies, of course, just to state the obvious, are the ones that have maximal benefit to muscle with minimal side effects, including the kinds of side effects we're talking with respect to the endocrine and bone systems. People have tried to tease out the relative benefit and risk of different steroid regimens, and I know that there's lots of different steroid regimens that are used in different parts of the world. Here we're looking at daily deflazacort, intermittent prednisone, and deflazacort 10 days on, 10 days off, and lack of steroids in terms of the risk of fractures. And what we can see is that daily prednisone and daily deflazacort have the highest risk of fractures, followed by intermittent prednisone and deflazacort 10 days on, 10 days off in this case. And then steroid naivete has a fracture risk as well, but it's lower than the other steroid regimens. But the issue here is that when there is an intermittency to the steroids, there can be an adverse effect on muscle strength. And so that's something we have to just balance. And what is the priority here? And that's a very individual decision. But here we see with intermittent prednisone, 10 days on, 10 days off, compared to daily prednisone and daily deflazacort, is that the intermittent prednisone group started to fall away from the daily steroid-treated groups in terms of muscle strength at about a year, and that became significant by 3 years. So certainly, tinkering with the steroid regimen can spare side effects, but it may come at a cost to muscle strength, and that is something that really needs to be discussed with your care provider to understand how your steroid regimen manages that balance between benefit to muscle and attenuation of side effects. People always say, well, what is the risk of these side effects? And as a general rule of thumb, this is not 100%, but it is a general rule of thumb, that if an individual is on some steroid regimen, whatever that is, and they develop the Cushingoid appearance, which is the round face and the central puddling of fat and the excess weight gain, that side effects are more likely in general, including growth and pubertal delay, fractures, and the metabolic consequences of the excess weight. And if the Cushingoid features are less, then the side effects are typically less as well. Now, regardless the steroid regimen that an individual is on, whether it's weekend only or twice a week or 10 days on, 10 days off or daily, we assume that all patients taking steroids have adrenal insufficiency, adrenal suppression, because it's such a serious complication of glucocorticoid therapy. So we need to take a proactive and conservative approach to that aspect. So how are we thinking as we go forward with the management of these issues in Duchenne, whether you're on steroids or not? Well, we've developed the OptimizeDMD consortium, which I mentioned a couple of days ago, that is fueled and supported by PPMD. This is an international consortium, and learning how together we can maximize the benefit from muscle-targeted therapies by minimizing the unwanted adverse effects on the endocrine and bone systems of those therapies. And we have our partners from Italy here with us that we're working with. We have an ambassador program where we take our learnings and we meet others around the world in order to hear where they're at in the care of these issues in their patients. So I'm going to go through each of these endocrine and bone issues one by one and let you know where we're at. So adrenal insufficiency. What happens is when someone is on steroids, the adrenals go to sleep. They sit on top of the kidneys. The adrenals are there. They become a little bit atrophic, a bit small, and they get sleepy. And so the problem with that is that when an individual has a stressful medical event like a surgery or an illness, a fever, then the body can't mount its own healthy response to that physical event. So we have to give extra steroid, known as steroid stress dosing, in order to manage that. And so what we're doing as part of OptimizeDMD is launching a massive education and awareness campaign so that we can ensure that every patient has the tools that they need to be on steroids safely in this regard. And that means everybody having a medical alert bracelet and a home and in-hospital steroid stress dosing plan. We're modifying the PJ Nikoloff protocol. We're developing family information sheets that are updated to include vamorolone. We're submitting peer-reviewed manuscripts, and we're developing materials to give webinars that can be broadcast around the world. So we're very passionate about this aspect, and Dr. David Weber, who is here, is leading the adrenal insufficiency working group as part of OptimizeDMD with other colleagues. And the thing about adrenal insufficiency is it's serious if unrecognized, but it's easy to treat if recognized. So as endocrinologists, for us, this is bread and butter to manage adrenal insufficiency. We got this. It's a matter of just making sure everybody is aware. The other serious complication in this space is low bone mass and bone fragility. When the bone gets fragile, then there is the potential for something called fat embolism syndrome. So what is that? Fat embolism syndrome is when someone has subnormal mobility, particularly if they're on steroids. There's an accumulation of fat in the bone marrow. And then at the time of a bone injury, a bone bruise, not even a fracture necessarily, but a fracture as well, those adipocytes get released into the circulation. They coalesce to form fat globules, and they can shower the lungs and cross the blood-brain barrier and cause respiratory distress. And this is serious, can be treated, and steroid stress dosing is part of managing the fat embolism syndrome. But all that to say, we really care about optimizing bone mass and preventing fractures as far as possible. You may have experienced a fracture in your journey, or one of your loved ones may have, and so you know how significant a fracture of the femur, or the tibia, or the forearm can be. It can take individuals off their feet prematurely, and of course is associated with pain and sometimes the need for surgery. We also see spine fractures, largely driven by the steroids, that can also be painful and lead to loss of the height of the vertebral bodies and then decrease the capacity to take a big breath. So we really care about preventing fractures. We know that the long bone fractures are largely driven by the myopathy. So the thing that's going to best restore the ability not to fracture is going to be restoring dystrophin. And we know that the vertebral fractures are largely driven by the glucocorticoid glucocorticoid therapy. So to mitigate vertebral fractures, we're going to need a steroid-sparing or relatively steroid-sparing approach. This is the current bone health monitoring and treatment paradigm in Duchenne muscular dystrophy. It's part of the 2018 care considerations, and we consider this the minimum standard of care for treating bone issues in this context. So first of all, we recommend that around the time of diagnosis and no later than steroid initiation that individuals undergo a bone density test. And then if an individual is on steroids, there should be spine imaging looking for those vertebral fractures every 1 to 2 years. If they're not on steroids, the imaging is every 2 to 3 years, or more often for both if the BMD drops at the spine. And then we start treatment at the very earliest sign of bone fragility, which could be a vertebral body having just a little bit of compression or a single long bone fracture. And that would trigger bone protection therapy as a minimum. And we recommend IV bisphosphonate therapy as first-line therapy because IV therapies are potent. Oral therapy not as potent, but oral therapy is certainly an option if that's what a patient prefers or if that's what a clinician has access to. And then we recommend continuing bone protection for as long as the individual is on steroid therapy. If they're not on steroid therapy, we recommend continuing if there are ongoing bone health deficits. Now, this is what happens when we give IV zoledronic acid. This is a study where we compared IV zoledronic acid to IV placebo in children with steroid-treated disorders, including 38% who had Duchenne. And you can see in red on the right that the BMD Z-score at the spine went up significantly, and then in blue, the BMD Z-score declined. No study has been powered to look at fracture rates on IV bisphosphonate therapy, but there is trend towards a decrease in fracture rates in all of the studies that have looked at IV bisphosphonate therapy. So this is where we've come in terms of our osteoporosis management. In 2010, the guidance was only to do a spine x-ray if there was back pain or spine deformity, and then to use IV bisphosphonate therapy if vertebral fractures were detected. Then we learned that vertebral fractures are often asymptomatic, and so we had to go looking for them. And the guidance then changed, that we recommend giving bisphosphonate therapy if there are vertebral fractures upon this routine surveillance or a single low trauma long bone fracture. And where we're headed now, and started thinking about this in 2023, is how can we prevent first ever fractures, since this is such an important space, and this is called primary prevention. So we're thinking about this, and we're talking to families, and we're saying, when is best? At diagnosis? Should we start bone protection at steroid initiation? Should we start by 1 year post-steroid initiation to give families time to adjust to the diagnosis? Should we start prior to significant decline in ambulation? Certainly the bottom line biologically is to start as early as possible, but we recognize that it is not easy to think about adding yet another therapy early on in the disease course, that families have a lot to cope with already. And we also recognize that it may not be obvious to do an IV therapy or even an oral therapy in a very young child. So we appreciate these issues, and so the timing of bone protection to prevent first ever fractures is indeed nuanced. But here's some of the biology. So we know that the bone density really plummets once there's loss of ambulation. And you can see on the right, if you track your eyes to 2 years, this is looking at a tibia in a boy with Duchenne from the top down. And on the top, this is a boy without Duchenne at the tibia, and you can see quite a bit of red, meaning there's quite a bit of bone there. And then in the middle, this is a boy with Duchenne who's walking, and there's a little bit of Swiss cheese there, a little bit of holes in the bone. And then once the boy has lost mobility, then we really see that trabecular volumetric BMD plummet. So we think that when we think about preventative primary osteoporosis therapy, we need to be getting to the individuals before loss of ambulation. The other thing is we think we need to be getting to the individuals before there are significant signs of steroid exposure, which include those Cushingoid features I mentioned earlier, growth delay, weight gain, and declines in BMD. So this is what we're thinking about going forward, and we're developing risk modules or risk sort of scores in order to understand who merits the primary osteoporosis approach at what time in their disease course. And we're thinking about getting to the individuals before there's significant loss of muscle function, before the time to stand is more than 5 seconds, and before there's those significant signs of steroid exposure. Now, I've been interested in the way that artificial intelligence can relieve me of some of my work and allow me to work top of scope as much as possible. And so this is interesting. This is Bone Expert, which is an AI program that takes the left-hand X-ray done for bone maturation and calculates the bone health index, which is a surrogate for bone strength. And we have shown that the lower the bone health index, the more likely an individual is to have a high fracture burden in the Duchenne context. So this is something that we're working on and figuring out how best to predict who's going to have fractures in their disease course and at what time point. What about weight gain? So weight gain is a big issue, isn't it, for some individuals on steroids? And there certainly seems to be individual-specific variability. Some have a tendency to gain weight on steroids, some don't. Sometimes it's a matter of the regimen that an individual is on, but there's a lot of variability here. The issue with weight gain is the way that it impacts the metabolic situation of the individual. So we know that excess weight is associated in anyone with increases in insulin and glucose and blood pressure and cholesterol, and also an accumulation of fat around the liver and the pancreas, which can interfere with the way those organs function. So what we started to do is to think about the following. We know that if we're going to do something meaningful to prevent weight gain, we've got to intervene early. If any of you have gained a little bit of weight in the audience, you know how hard it is to get it off once it's on. So it's all about trying to prevent it getting on in the first place. So we're thinking about the role of early anticipatory intervention with insulin-sensitizing medications that are good for insulin metabolism and sugar metabolism, but also for weight control. We're thinking of medications like metformin and liraglutide and semaglutide. Now, these medications also cause nausea, so it's not so obvious to just rush in and use these, and we're sensitive to the way in which the nausea may impact the quality of life of an individual who's on these medications. So we're putting our toe in the water of using pharmacotherapy to try to rein in the excess weight gain in those for whom that seems to be an issue. And we do think we need to get to it early rather than trying to do something about it late. Now, what about puberty? Steroids can delay puberty, and we have very good guidance there. We know that puberty typically starts in an individual who is not on steroids around 12 years of age. So puberty is normal in Duchenne if an individual is not on steroids. And so we start to talk to the individuals around 12 to let them know that if they're on steroids, puberty may be delayed, and just to let them know that we have ways of helping with that. The issue is that not everybody's ready to talk about puberty between 12 and 14 years of age, or they might be ready to talk about it but not ready to do something about it, and we're very sensitive to that. This is not something that has to be done. This is an option, and we're there for the patients to support them through those conversations. There is some evidence that inducing puberty in those who have pubertal delay due to steroids can delay the progression of vertebral fractures, and inducing puberty is important for cognitive maturation as well. But this is a sensitive space. We have different options for inducing puberty: intramuscular testosterone once monthly, subcutaneous every 2 weeks, and gels, sachets, or pumps. Although if you use gels, mom has to stay away from that or she'll get a little bit furry. And even dads don't need more testosterone than they either have. So we find the families really prefer the intramuscular and the subcutaneous testosterone. Now, what about growth? So growth in steroid-treated Duchenne is variable. If you're on a weekend only or a twice weekly, your growth may be normal. If you're on daily, your growth is likely to be delayed. And again, it depends on the extent to which you have those Cushingoid features as to whether your growth is likely to be different or not. And so this is just a typical growth curve of an individual who's on daily glucocorticoid therapy. We talked a couple of days ago that the growth failure in Duchenne is usually not hormonal. It is not a lack of growth hormone or a lack of thyroid hormone or a lack of testosterone, because testosterone doesn't mediate growth all that much when you're on steroids. It truly is a problem with the growth plates having been put to sleep on glucocorticoids, just like glucocorticoids put the adrenal glands to sleep. So the growth plates are stunned, and you can give growth hormone, but you're not going to wake up the growth plates to any significant extent. Hormonal therapy, growth hormone therapy for the growth failure of Duchenne is not standard of care, does have side effects. If you embark on that, that would be an individual decision that you would make with your clinician, and it would be one that you would undertake with close monitoring to understand the relative benefits versus the relative side effects. Now, the novel steroid vamorolone, which I've heard a lot of people talk about here, is growth sparing, at least out to 3 years, which is what we have data for so far. So I want to finish up by talking about vamorolone, which is a novel dissociative steroid, where the goal was to see if we could separate the good from the bad. Is there a way we can retain the anti-inflammatory component of this drug, but minimize the side effects that are associated with this? So let me finish up with a little high-level overview of vamorolone, which is also known as Agamree, but I'm used to saying vamorolone, so I'm going to go with that. So what do we know? We know that it retains its anti-inflammatory benefits to muscle with data up to 3 years of use relative to daily prednisone at vamorolone's highest dose, 6 milligram per kilogram. That's what we know so far in terms of the protection to muscle. And we know that it improves some of the side effects related to the endocrine and bone system, but not all of them. It seems to be particularly protective for growth. I would say vamorolone appears growth sparing. And vertebral body strength appears better, although we do still see occasional vertebral fractures. So vamorolone is distinct from the traditional corticosteroid class because it lacks an 11-beta oxygen. Basically, chemists have taken the classic steroid molecule and they have altered it slightly so that vamorolone interacts with its receptor slightly differently and brings about these different effects. So just to show you, I built this. Let's see if this is going to work. Doesn't seem to. Oh, there we go. So this is prednisone. No, this is deflazacort. And this is what the molecule looks like. And then vamorolone looks very much like deflazacort. There's just been this small conformational change. And that is different enough to make the molecule different enough as a medicine to prevent some, but not all, of the side effects in this space. And I have a similar video for prednisone, but it looks like I passed over it, so we'll just move on. So here's what we know and what we don't know about vamorolone. And I think when there's a new therapy available to a community, it's so important to understand what we know and what we don't know and what we need to learn more about so that you can take this forward as you think about the role of a new therapy, any new therapy, in the life of your child, your loved one, your family. So we know vamorolone normalizes linear growth up to 3 years, and clinically it looks like it normalizes growth even beyond that in my experience. We know that it improves bone turnover, meaning that the bone is more active and dynamic, and we think that's a good thing. And we know that it reduces but does not eliminate vertebral fractures. We know that it does not prevent excess weight gain in all patients. There's quite a bit of variability in terms of that particular response. And we know it does not prevent adrenal suppression. We also know you can't use vamorolone to stress dose. You must use hydrocortisone. And then what we don't know is whether beyond 3 years of use, it has a similar effect on muscle strength as daily prednisone or deflazacort. We don't know the effect on scoliosis or cardiorespiratory health over the long term. We don't know if it normalizes pubertal development, and we don't know if it reduces long bone fractures. So let's just finish up by walking through each and every one of these with respect to vamorolone. So just quickly, you can see that vamorolone decreases morning cortisol levels. Vamorolone 6 milligram per kilogram is in black, and it does so to a greater extent than prednisone in red daily. And then these are the stimulated cortisol levels, and you can see that vamorolone 6 milligram per kilogram has the greatest degree of adrenal suppression relative to prednisone in red, vamorolone 2 mg per kg in hatched, white, black, and placebo had the highest ACTH-stim cortisol levels, of course. So the adrenals are still sleepy on vamorolone, and the higher the dose, the sleepier the adrenals. Everyone on any steroid of any regimen, whether classic steroids or vamorolone, is assumed to have adrenal suppression and treated accordingly given the seriousness of that side effect. And so everyone on vamorolone should, at the time of their prescription, be given a prescription for oral hydrocortisone. We want to see you get both prescriptions at the same time. Here's your vamorolone, here's your hydrocortisone, and your plan for that hydrocortisone. What about vertebral body strength? Well, this is a study where we took children who were on vamorolone at 3 years and did a spine x-ray and compared those to children who participated in the 4DMD study and received daily prednisone or daily deflazacort, and they had an x-ray at 3 years. And so we can see that the vertebral fracture prevalence on vamorolone after 3 years is 13%. So 13% of patients had at least one vertebral fracture, compared to 26% on prednisone and 28% on deflazacort, both daily. And we didn't see any vertebral fractures on intermittent prednisone, 10 days on, 10 days off. And you can also see the vertebral fracture severity was less on vamorolone, and the number of vertebral fractures was less on vamorolone. So vamorolone does seem to protect the spine to some extent, but there still are some vertebral fractures, so we recommend that individuals continue routine bone health monitoring, as I mapped out earlier in this talk. What about metabolic bone activity? This is how dynamic the skeleton is. And these are bone turnover markers, and I'm not going to go into detail, but the line in the middle is normal, is average for a typically developing population without Duchenne. And we can see that these bone turnover markers, these measures of bone activity, are normal up to 30 months. And then this is what happens when you take prednisone. Your bone turnover markers crash no matter which one you measure. And then if you go from prednisone to vamorolone, they shoot up and normalize. So bone activity really is quite normal on vamorolone. And if you're on prednisone and then go on vamorolone, the bone activity normalizes rapidly. You don't have to be on vamorolone for very long for that rapidity to show. But we still see long bone fractures on vamorolone, and why is that? The bone activity is better. Why are we seeing long bone fractures? It's because the dystrophinopathy, the muscle weakness, makes the bones thin. And so the only thing that is going to make those bones thicker is muscle strength. So that's why I say we have to continue to monitor bone health as we already are. And we don't know whether the long bone fractures are less on vamorolone or not, and we're studying that. And then growth, so this is just to show you that the growth goes down on prednisone in the hatched peach and burgundy, and then when you go on vamorolone, the growth improves rapidly. And if you're on vamorolone from the beginning, 6 milligram per kilogram, which is the efficacious dose, growth is normal. So vamorolone really is positive where growth is concerned. And then this is just showing you the same thing, but not such a busy slide where growth crashes on classic steroids daily and then improves when you go on vamorolone. In terms of the weight gain, as I said earlier, there does seem to be some variability there, and overall it looks like most patients gain weight on vamorolone. And if you look at the right, you can see that the vamorolone patients in blue had a weight gain that was fairly similar to patients on different steroid regimens over a 3-year period. Now, there is some data to suggest that maybe the weight is pulled back a little bit on vamorolone, but I must say I'm just not really seeing that in the clinic so much. I'm seeing variability in weight gain just as I do with classic steroids. So vamorolone, with data up to 3 years of use, seems to really show robustly normal growth in terms of linear growth. Bone turnover markers are improved, which theoretically should lead the bone to be able to better adapt to mechanical loading and perhaps better undergo fracture healing, although that's theoretical and has never been proven. And there's fewer but not absent spine fractures. We don't know the frequency of long bone fractures. We don't know the frequency of scoliosis on vamorolone. We don't know about cardiometabolic and respiratory health over the long term. And we don't know about muscle strength beyond 3 years. And so with that, I'll just conclude by showing you a picture. This is the OptimizeDMD osteoporosis working group. We meet monthly, and we strategize how we're going to continue to try to make things better for families, no matter what steroid they're taking, or whether they're on steroids at all, or whether they're on vamorolone, and moving the dial, working with our partners, such as those in Italy and around the world, with clinical care, education, advocacy, and research at the heart of what we do, fueled by what the families need. And with that, I thank you for your attention, and I wish you all the best as you go forward. If you have questions, I'm very happy to address them at any time during this conference. Thank you. And with that, it's my pleasure to introduce Maitea Guridi. She has come from Europe to speak to us about a novel therapy that has the potential to target both muscle and bone. Maitea.
Hi, everyone. My name is Maitea Guridi. I'm a scientist by training. I work as a development leader for Roche, and I'm here today to tell you our story, the story of how, well, I'll tell you all about bone health a little later. Right now, I'm going to tell you the story of how we were able to use the data and the blood samples from one of our previous clinical trials that was unfortunately terminated early due to a failed study, but how this study still helped us figure out the potential of a new treatment for DMD, which is called satralizumab, and this is what we think could be bone protective in DMD, and how also the data from this previous clinical trial helped us design a new clinical trial in Duchenne focusing on bone health. So this is why we're sharing the panel today. Actually, I would like to first of all thank Leanne, not just for agreeing to share her session today with us, but also because she has been tirelessly working with us for the last over a year. First of all, helping us understand and learn as much as possible about bone health and bone fragility in DMD. And also she has been helping us figure out the best design of a clinical trial focusing on bone health in DMD. So thank you, Leanne. And thank you, obviously, to the organizers and PPMD for giving us the opportunity to present our story and be here today. This is the green button here. No? Yes, I'm required to tell you that the content of this presentation, which is literally 2 slides, it's for information use only, and we have no promotional purposes. So let me start by telling you that us at Roche, we remain committed to advancing treatments for different neuromuscular diseases. These are some of the molecules that we currently have. You might have heard about, for example, risdiplam, which is an approved drug to treat spinal muscular atrophy. You've obviously heard about Elevidys. This is the gene therapy approved for Duchenne muscular dystrophy that we co-developed with our partners at Sarepta. But some of you might actually remember us better because of one of our previous molecules, which is the anti-myostatin and the Spitfire clinical trial. So the Spitfire was unfortunately terminated early. This happened in 2019 because we saw that, unfortunately, the anti-myostatin did not work for DMD. And this was a huge, huge disappointment for all of us. I think we always tell we tell the families, people living with DMD, that it's very important for you to participate in clinical research, to join our clinical trials, because you're helping us advance our understanding of the disease, potentially figure out new treatment avenues. And this is true even if a clinical trial fails, because actually clinical trials don't really fail. The molecules might not work, but the clinical trial is successful in helping us gather so much valuable data and helping us advance the science and understand the disease and come up with new ideas. And this is literally the example that I'm sharing with you today, where even though Spitfire was terminated early, we were able to use the data and the blood samples from this trial to figure out a whole new possibility of a new treatment and come up with a new clinical trial. So us at Roche, we're super excited to be back collaborating with the Duchenne community, and especially with this particular emphasis or focus in bone health. As Leanne has told you, we have been learning so far, and I hope everybody is now aware that bone health, bone fragility is a critical area of high unmet medical need for people living with Duchenne. So how did it all start? It's literally, it was a couple of years ago. We got together a group of scientists and we started thinking, okay, what else can we do to continue improving lives of people living with DMD? What other treatments could we have that could help? And while we were analyzing the data from the Spitfire clinical trial, we actually saw a very fascinating fact. And this is the fact that almost all of the participants in the Spitfire clinical trial, they showed a progressive loss of their bone mineral density. This is something that Leanne was just telling you about. We had 166 participants in Spitfire. They were ambulatory kids aged 6 to 12. And almost every single one of them had a progressive loss and decline on their bone mineral density. We saw significant losses already at 6 months after baseline, and this got worse even at 12 months or a year after baseline. We did this through a DEXA scan, which measured the bone mineral density. So we realized this is a real issue, and we wanted to learn more about bone health in DMD. So we decided to go a step further, and we used the blood samples from the placebo participants in the Spitfire clinical trial. You know this little box in the informed consents, when you're thinking about participating in a clinical trial, there's a little box where you say, yes, I agree for my samples to be used for future research. Thank you. This is literally what helped us and what allowed us to perform this new analysis. We were able to use the blood samples from the placebo participants in the Spitfire trial and compare them to healthy volunteers, age-matched healthy volunteers. And we found something that was not known until now, and for us it was very interesting. We found that the DMD participants had higher levels of a protein called IL-6 receptor. So IL-6, or interleukin-6, is a protein that is involved, it promotes inflammation. And we saw that in the participants in the Spitfire trial, the protein levels of IL-6 receptor were higher in their circulation compared to healthy volunteers. And we went even a step further, and what actually triggered us to come here today and to start a whole new clinical trial was the fact that we saw that the levels of this protein, the IL-6 receptor, correlated with the bone mineral density of these participants. So we saw that in those participants with a higher level of the protein IL-6 receptor, they were also the ones showing a lower scores in their bone mineral density. So the idea came up, what if we blocked IL-6 receptor? Could we restore some balance? Could we actually prevent participants, or the people living with DMD, could we prevent them from losing bone mineral density? And this is the whole story of how we came up with the idea of a new clinical trial and a potential treatment for satralizumab. And I'm going to be telling you all about our new clinical trial, SHIELD DMD, in the next session. But for now, I just wanted to reiterate, thank you for those who participated in Spitfire. Thank you for those who still participate in clinical trials. As you can see, it helps everyone. It helps us continue, and we can work together to figure out potential new treatments. And this is it. Thank you for your attention.